So coronary microvascular dysfunction, or CMD, it's associated with a slew of cardiovascular abnormalities. You've heard many of them before: diabetes, hypertension, obesity, chronic kidney disease, ANOCA, HFpEF, female sex, age, a slew of other hypertrophies, hypertrophic cardiomyopathy, amyloid, Fabry, aortic stenosis, and other non-ischemic cardiomyopathies, including the genetic cardiomyopathies. So it's a big challenge. Going back. So when we compare the different imaging modalities for assessing coronary microvascular dysfunction non-invasively, we can do it with echo, CT, and SPECT, although if you look down at the bottom row the row about accuracy, there it's somewhat limited, but we have excellent accuracy with cardiovascular magnetic resonance and with PET. PET obviously has a ionizing radiation component. If we compare PET and CMR, the precision and repeatability are both excellent for both of them. Availability slightly more for CMR, although not a lot of sites have it here in Australia, but internationally. But we also have not very much PET in it here in Australia. And then the published data is slightly on the advantage of PET, but MR is coming on strong. CMR has a slight drawback with devices. Not all devices, pacemakers and ICDs, preclude us from having a CMR, but sometimes they cause problems with image quality. PET does not have that problem, but it's more the availability problem. So what can we see? Here's using rubidium PET. The top row shows in the middle the stress and rest PET images, and on the top right, the CT showing non-obstructive coronary disease, no obstructive coronary disease. In the bottom left, we see a bullseye plot showing the rest myocardial blood flow, and in the middle, stress myocardial blood flow. And this, in both cases, is measured in milliliters per minute per gram of that color scale that we see. So we go from a blue, where the average LV value is 0.8 mils per minute per gram, to the yellowish, where it goes up to 1.3 mils per minute per gram. And if you divide stress by rest blood flow, you get the right-hand side plot, which is the coronary flow reserve, about 1.6. Anything under 2.0, that is an inability to double your myocardial blood flow with adenosine stress, is considered coronary microvascular dysfunction, especially when it has a global pattern like this. By analogy, we can also do that with cardiovascular MR. Here are representative midventricular short axis slices taken out of a bigger series. Top row is adenosine stress, and bottom row is rest. And we see the left ventricle, the blood pool is white, but on the bottom left panel, we see in dark blue coronary myocardial blood flow of 0.8 mils per minute per gram. That in health, on the left-hand panel top, goes up to 4.9 mils per minute per gram. So that's a six-fold increase in health. In the middle column, in single vessel disease, we see a focal perfusion abnormality designated by those arrows, so right coronary artery territory ischemia, but the yellow in the rest of, normally perfused in the rest of the myocardium. But compared on the right, where we have coronary microvascular dysfunction going from about 1 up to 1.8 mils per minute per gram, so a globally attenuated ability to increase the myocardial blood flow. All those images are on the same color scale. So where do we see coronary microvascular disease? Not only in the setting of various the spectrum of coronary disease as such, but we see it in amyloid heart disease, we see it in hypertrophic cardiomyopathy, we see it in MINOCA. If we just take a look at that middle column there, healthy volunteers have a good perfusion, but even in subclinical genotype positive, phenotype negative hypertrophic cardiomyopathy, we already see reduced perfusion. So particularly in HCM, it's something that's catching disease earlier than otherwise in the absence of any direct coronary artery disease. So in summary, because we had a limited amount of time in this little rapid fire session here, coronary microvascular dysfunction is massively underdiagnosed. We don't have necessarily all interventionists willing to put down a wire and add the hardware necessary to diagnose. So it's being underdiagnosed. So there's an opportunity to diagnose it non-invasively. It contributes to many cardiac disease states, not only in the coronary spectrum, but in other aspects of the the cardiomyopathies, but it can be measured by many non-invasive modalities, and both PET and cardiac MRI can do it excellently. So reach out to a center near you and ask them if that's a possibility. Understandably, it's not reimbursed in Australia. The politics don't affect necessarily don't negate the absence of the problem. So if your patient can afford it, that would certainly be an opportunity. Thank you for your attention.